hear me? Somebody say,
Yes.
awesome, thanks.
Yeah, we
Thank
can hear you.
thank you,
Yes,
awesome,
we
thank
do.
you. Thank you. So we have the Health, Equity, and Rights team is excited to introduce the following presentation, highlighting a really interesting partnership between CARE India and the Bihar team. And its Bihar team, along with the Harvard Humanitarian Initiative. Jessie Rattan from her team, who a lot of you know, recently left CARE to pursue her PhD, but she helped pretty much guide the partnership along with the folks at CARE India, and transferred the responsibility to me to introduce it to CARE. So we feel that this important relationship or project actually feeds into and illustrates a lot of really core elements of CARE's right to health strategy, CARE International's rights to health strategy, efforts to develop a scaling up framework, the trend towards localization, CARE's new frontline health worker strategy, and there's general elements of CARE's focus on gender. So the presenters will be Michelle, I'm going to hopefully get the pronunciation right, Nishenko from Harvard Humanitarian Initiative. I believe she's with Boston, excuse me, the Brigham and Boston's Women's Hospital, along with Sean, please correct me when you guys get on, and Sean Kivlahan. They are both emergency physicians who served as technical experts for adult emergency care and pediatric emergency care, who oversaw the project and were responsible for the development and implementation of the project throughout its entity. This also has been facilitated as project manager, Carolyn Baer, who was a former senior technical advisor on sexual and reproductive health in emergencies for CARE, and served as program, and as I said, served as program management of the project. Just very quickly, this project between the Harvard Humanitarian Initiative and CARE India was established to support public hospitals in Bihar state, where we've been implementing, as many of you know, a very large-scale health program to promote and demonstrate safe emergency care through a mixture of didactic and real-time training interventions. Additionally, the Harvard and CARE India clinicians worked alongside hospital staff to strengthen emergency planning and preparedness practices in response to the COVID-19 pandemic, as well as to sustainably improve services for patients seeking emergency care for other conditions. So with that, I'm going to hand it over. I'm not sure if it's Michelle or Sean who's going to speak first. So I hand it over to whichever one of you is going to speak first. Michelle or?
Thanks, Phil. I think Sean and I will just quickly introduce ourselves to you all.
Great.
Good morning, good evening, good night. I'm Michelle Nishenko. I'm a pediatric emergency medicine physician and a public health physician. I'm at Boston Children's Hospital. And our sister hospital is where my colleague Sean is at.
Hi, everybody. Thanks for joining us today. And as Bill said, my name is Sean Kivlahan. I'm an emergency medicine physician in Boston at Brigham and Women's Hospital. And I've been working closely with Michelle and Carolyn and the rest of the team on this project. And we're excited to share our experience with you.
And so I'll be your presenter today. So I'm just going to share my screen. And I see some of our colleagues, which you'll hear a lot more about from the Bihar team on. Hi, Dr. Sanjeev. And so this is a summary of what became the Be Prepared project. And so it's Bihar Emergency Preparedness and Response Didactics. And this is a project summary and a little bit of an early impact report for you. The intervention is actually just finishing up this month, and so the final data is not complete, but we did some analysis to be able to share with you today. And so just to give you an overview of where we're going, we're going to give you a little bit of background on how the project came about, a summary of what the project actually did, our intervention, and then some preliminary results, as well as opportunities for the future. And so here on the right, you can see one of the intervention hospitals at the very beginning, before any work was done in Samastipur, which is the central district in Bihar. And so for some background, this project was really motivated by the Delta variant wave that struck India in May 2021. The public and the media all over the world witnessed the more than 3 million deaths that occurred. The picture that you see in the middle of an ICU setting was a rarity. This was private facilities where there was lots of equipment. You can see in the picture, PPE, patients getting cared for. But the majority of the public health facilities were unprepared, and an urgent need to strengthen their health system at the front door of the emergency department, where all the patients come, was identified. And this was critical because these public hospitals were really unable to serve their population when needed when this surge happened. And this is, I think, where the experience of Care India and Care USA together came in. As Bill mentioned, there was more than 20 years of maternal and child health experience. If you look, there's more than 70 publications about this work on maternal and child health and their experience in hospitals, which is rare amongst NGO partners. Most focus really at a community or clinic level. It's just easier. Hospitals are complex. They're, varied in their needs. The Care India team had also developed a really excellent mentorship model, specifically focusing on nurses, and had just unbelievable government collaboration in the work that they were doing. And so this was a ripe opportunity to then think about how do you tackle another really difficult problem of lifting up emergency care in an emergency. Emergency care is complex. It's cross-cutting. You need to be able to treat every condition, day or night, spectrum of age, really everything. It's often emotionally charged. People come to the emergency department stressed, and this is also perceived to be resource intense. I think this picture on the right really sort of sums up emergency care. This young woman has been in a motorbike accident. It's 1 o'clock in the morning. You can see the pitch black night sky of those windows. And this woman needs to be able to receive care by a physician ready for trauma, a nurse ready for trauma, get x-rays, have lab studies done in order to meet her needs. And how do you make sure a system can do that at the front door every day, any time of day? And so the solution that we really worked together with the Care India team on was to target these frontline health workers with an emergency care health system intervention. They can't function in isolation. They must have the tools around them. And then how do we deliver it at scale, recognizing that if you solve one hospital's problem, you haven't really fixed the more cross-cutting problem. And so to do this, we really had to build a team. And so the Care India team really led this with their existing relationships with the government and hospitals and their frontline health worker strategies. The Care USA team also helped us, Jesse, with the experience in India and other locations, a large-scale intervention. Our technical team is the Harvard Teaching Hospitals, bringing pediatric and adult expertise, some of the content and education in other countries we've worked in doing emergency care training, but then also our experience in scaled interventions. And so we've had work managing hospitals during Ebola. We supported a 23 hospital system to keep them functioning during that crisis. And so that scale and replication piece, as well as then the Ministry of Health in Bihar, who really invested in this project when it came to the needed things like human resources, supply chain, government facilities. And so together, we're then able to deliver an intervention. So the objectives of the project sort of immediately in the 6-month pilot were emergency care improvements. Anybody who walks through the door can receive better and improved care for the conditions that they have. But to do this really localized, using Indian expertise. Emergency medicine is a specialty in India now, and there are Indian emergency medicine doctors. And then there are nurses who are well-trained, especially through the Care Maternal and Child Health work, to be ready to meet these needs. And then thinking long-term after 6 months, how do you sustainably integrate this into each hospital's operation so it lasts? Can you use it to adapt and disseminate new material? So for example, should a new wave come about with COVID, another new disease or outbreak, plus higher levels of care? How do you expand from what they're providing now to go up for, say, breathing support or otherwise? And then how do you scale it? Could this be a defined package that could go to other hospitals in Bihar or India, or even to other countries? And so to summarize kind of what we did in the intervention, is, in Bihar State, there's 130 million people, 38 districts. And so 5 districts were identified by the CARE India team, 2 very rural, 2 very urban and very populated, and another very central district with a lot of government engagement. So we had the full gamut to make sure that this would work everywhere. And the intervention then brought together sort of 4 pieces of the pie. Renovations, so improving the physical space. Human resources, making sure the right people are present at the right times. Education, being able to deliver content to the people in place. And then equipment, making sure they have the tools they need to then deliver what they learned. And so taking this intervention and unpacking a little bit for you, when it came to renovations, this was not about having a flashy emergency department. This was about making the space they had fit for purpose, improving the working conditions for staff, incentivizing them to be present at work, to use the knowledge they have by having the space to do it in, and then also to build the public's trust in this space. The focus was really on functionality. And I have to really compliment Dr. Sanjeev and the team who worked so hard on this to ensure that every aspect of making an ER functional was taken care of. And so all the red in this diagram are the changes that were made at one of the hospitals. And these were not huge changes, but really important. So things like bathrooms, so that there were bathrooms for nurses and doctors who were often female and male respectively. Nurses were missing work due to menstrual hygiene without a bathroom accessible to them. Having privacy screens in place for the patients so that women could be in the ward and stay in the emergency department. Lighting for safety and security. There was one hospital when we started, women nurses were not allowed to work at night because of security and safety between bathroom availability and lighting. A lot of these things have really been addressed. You then take the human resources. And so, CARE in India really added personnel temporarily to fill some of the gaps, while the state government started adjusting needs, shifting nurses, shifting the schedules to target busy times of day, getting the doctors to consistently attend their shifts, which was a problem when we started. And then as we arrived and started the project, they were already expanding to 24-hour X-ray and CT, but now the government's working on expanding laboratory hours, which when we started were only between 8 a.m. and 2 p.m., leaving 18 hours of the day without lab, inability to diagnose a heart attack or check an anemia level. The nurses also kind of took it upon themselves to create job aids. So these are some of the beautifully hand-drawn posters that the nurses developed to help new staff coming in know what to do and maintain their skills. When it came to equipment, CARE India temporarily filled the gaps with basic equipments like blood pressure cuffs, waste sorting systems, like kind of the immediate fixes, while the Bihar state government picked up on procurement of critical items. So now all 5 of these hospitals have an EKG machine, which is the only way you can diagnose a heart attack. They all have monitored bed spaces. This is a picture of one of our mentors teaching the use of a defibrillator for somebody in cardiac arrest, things that were not present just before the intervention. And then the mentorship model focused on using localized Indian talent, so the nurses and the physician experts, with international experts from our team together to do just-in-time teaching, so teaching at the bedside on sort of patient cases, doing didactics, like you see one of the nurse mentors here in the off hours, just gathering the team up to work through cases, and then bedside mentorship and procedures. And so you can see one of our mentors, Dr. Devon here, showing airway maneuvers on a mannequin. And all the education content was then prioritized by the Indian physician team to really identify what was the highest yield for population burden of disease. And so we had strong focus on some of the pediatric urgent complaints that come in, diarrheas, the pneumonias, but also importantly on the adult burden of disease, and especially non-communicable disease like heart attacks, strokes, and then some things that are very hyper-local like snake bite in this agricultural and rural area. And the education delivery was then focused to try to take these topics, give the providers the knowledge, but then also the skills to apply them. We really wanted to bridge that know-do gap. We don't want people to just know it. We want them to know it and then do it on real patients. And so that's why we combine the sort of 4 different learning modalities to try to get practical application. And so when we look at, again, we're still finishing up the intervention this month, some preliminary results. We did a survey of sort of the attitudes around emergency care of the providers before the intervention. And overwhelmingly, 97% felt like emergency care is important. But when it came to their confidence, only half of the providers felt comfortable caring for an acutely ill adult and 15% for an acutely ill child. And I think this is where one of our challenges as a pediatric ER doctor in maternal and child health, we have a lot of focus on getting kids access to care, getting them to the clinic, getting them to the health center. But when they reach this higher level of care, often the front door emergency department is not ready for them. Most children are cared for in a general emergency department, not in a pediatric specific unit. And so this low confidence really resonates with what's happening globally. Injuries also, low confidence for children especially, for adults about 2/3. And then we also did a knowledge check with the nurses prior to starting. The nurses scored only 32% on the basic emergency care knowledge they need to provide sort of frontline emergency care. So there was a lot of opportunity to really make intervention. And so what we looked at, this was a very human resource focused intervention around teaching and contact time. And so we looked at the mentor hours present. On the physician side, we had about 4,100 hours of Indian emergency medicine expertise and another 1,600 hours from our Harvard mentors. On the nursing side, we had over 5,000 Indian nurse mentor hours happening, combined with another almost 1,300 international expertise nurses, providing that contact time just to be in the unit, checking things on the spot, talking about cases, supporting them in real patient care. And then we had our mentors really document then their specific teaching hours. And one of the things we learned is that the physicians are very busy and they have to see the patients one-on-one. And so if you're moving 100 patients through that facility, that's 4 patients an hour, 1 every 15 minutes. And so the amount of teaching time over the 6 months was more limited with the physicians because of that volume. And we had more opportunity to engage with the nurses, almost double. And so when it comes to the topics and the sort of engagement, these are weighted word clouds. And so the mentors documented what topics they taught so that we could get an idea of what the frequency was. And what really resonated here is the large words, things like airway, review, trauma, breathing, are the basics of emergency medicine, the ABCs, airway, breathing, circulation. But it turns out we just spend a lot of time on the core knowledge to really bring that up, to start to reach more critical emergency topics like acute coronary syndrome or ACS, heart attacks, to reach topics like fluid management for nurses, supporting patients with wounds. And so there's a lot of room to build the weight of these topics. And to kind of give a sense, for example, in airway and breathing, the nurses would start with a didactic on the left, move to a skill and practicing on a mannequin or a simulator, to the bedside in a supported way. Here they're applying in the third picture a CPAP or an airway breathing device to a patient, to then put it all together to be able to use the individual skills and knowledge areas in a full resuscitation or sick patient. Similarly for trauma, demonstration in a controlled way, working on a mannequin hands-on, followed by actual real patient care, safely log rolling this woman to prevent any neck injury. And so measuring the way that you can apply these skills is quite difficult. There is a tool called the Medical and Trauma Care Checklist. This was developed by WHO as part of the Basic Emergency Care Package, which is the only globally existing emergency care education package. It's a short course, it's just 1 week. It was actually co-authored by my colleague, Dr. Kiblahan, on this call. And so we used this tool from this package. Our package was sort of more extensive and meant to be applied at the bedside as opposed to a 1 week short course. But we used this checklist to see if we could get changes in actual bedside care. And so what this checklist does is it allows us to watch an acute care situation, a new injured patient comes in, a new sick patient comes in, and be able to check off, did the staff do all of the necessary steps that would be needed to really properly assess and stabilize this patient? And we did this, our physicians did it as a sort of background observation. It wasn't done with the staff knowing that it was happening. They would pick 10 days a month, one resuscitation per day. So we got different teams, different combinations of staff, and they would fill out the checklist right after an acute situation to get an idea of sort of how well were the teams learning, picking up on these skills, and then also to be able to give real-time feedback on that particular patient scenario. And so what we found is it took us up until March, so the first 2 months really of the intervention, to get enough staff consistently working in the emergency department to even do the checklist. There was a real problem with staff attending their shifts. Once we had critical mass, we can see over the life of the following 4 months, as the teams worked together more education, more simulation, their overall performance on acute care improved for medical situations, so things like asthma or heart attacks, from 36% to 73%. And we were just starting to see an uptick in the trauma and injury care. And so we're really looking forward to seeing what this last month of data looks like. It's really also important, this intervention started reaching the public. And so this was very, very heavily covered in Bihar news media. Many thanks to Dr. Sanjeev and their team for publicizing it, as well as the Ministry of Health and our champion, Dr. B.K. Mishra. We sort of were able to sort of engage with the public to help build their confidence and draw them back to the hospital system, so they knew what was going on and could really see it. And I think nothing represents that more than this picture. It seems like a very simple picture. To set the stage, there's Sean and myself. I'm behind the X-ray conveniently, but we had the opportunity to visit all the hospitals with Dr. Shashank, who is holding up that X-ray. He's the lead Care India mentor, facilitated by Dr. Sanjeev and Dr. Sridhar and the team. And we visited the most rural hospital, Saharsa district, on a Sunday. And so we walked in on a Sunday, and this gentleman, who is the unsung hero of the photo in the head cover and the mask on the left, is the physician who was on duty. And so importantly, it was Sunday at noon, and this physician was present. He was rounding. And not only was he present and rounding, he was simultaneously treating a 12-year-old who'd been bitten by a snake, which would have been a fatal injury, on his 19th vial of antivenom, while having just diagnosed a 50-year-old gentleman with a heart attack who was getting what we call lice treatment so that his heart will heal and he can go back, work his farm, his livelihood for his family, while also treating an older woman with a stroke, interpreting this image that we looked at with him. And so to arrive unannounced on a Sunday, to find this gentleman deep in patient care was so different than when we started. And to see that level of change and interest and engagement was just amazing. And to know that these patients can walk in the door and receive the care they need to go back out as productive citizens or to grow up as healthy children. Unintended, but really positive, was the start of process improvement. And so as the nurses and doctors gained more knowledge, they became more invested in their environment and what was not working for themselves. And so each hospital started its own initiatives. Cross-cutting, each of the hospitals focused on cleaning. And so cleaning schedules were developed for the hospitals. The cleaners became an important part of the team, felt more part of the team and engaged with the department. It got so well functioning that the cleaning staff was cleaning, the environment was nice, renovations had happened, the nurses were taking vital signs on schedule, that it actually has become a problem at some of the hospitals that once the patients need to be admitted to the hospital, they don't want to leave the emergency department because they're happy there and they don't want to go to the ward. And so now this intervention sort of pushing into the rest of the hospital, triggering them to enact cleaning schedules, nurse vital signs, and it's kind of bleeding out across the system, which is a really great side effect of the intervention. Similarly, the nurses realized that the instruments, so things for suturing or giving injections, were not being cleaned between patients with a risk of spread of hepatitis, HIV. And so the nurses took it upon themselves to set up sterilization so that now all instruments go through a sterilization and autoclaving process, providing safe care for patients and nothing gets reused. These summary changes and all of the sort of time spent and the public engagement has resulted in, Dr. Sanjeev and I and Sean reviewed this data when we were in country together. Some of the ERs are now actually seeing a doubling of patient volume because the patients are actively choosing to come to the public hospitals over the private hospitals because they believe in the quality, and then the cost and price point for them is much more affordable. And so we're really looking forward to looking at some of the final data. And then really thinking about what are the opportunities for the future. This seems to have really taken hold, at least in these 5 hospitals. And so we think about flipping those maps. So these 5 hospitals were a pilot. How do we get this same intervention out to the entire state of Bihar and to all the districts so that all 130 million people have access to a similar quality of care? Ways to think about it are, we've tackled 5 hospitals in this pilot phase. As a team, we started to work through scenarios last month together around what does scale up look like? How do we, in this coming year, maintain 5 hospitals and help them grow and add 12 new hospitals? Following year, how do we maintain 17 hospitals and add 12 hospitals? To get to a year 3 where we finish out maintaining and adding the last of the hospitals. So we get a total system lift across Bihar state. And then what does that look like at a hospital level? This is a wordy slide, but I'm going to walk you through it. We need some better graphics with lines potentially making this a little easier to understand. But when we think about scaling up at the hospital level, there's sort of 2 tracks of work: the physicians who are less available and the nurses who are more available as far as time and contact hours. So when we think about the nurses, they're the base that this intervention sits on. They really run the ER, as they do at my hospital and Sean's hospital and most hospitals around the world. And so really using the nurses as the foundation of this intervention, where we start with a nurse mentor. We increase the knowledge for that ER for the first 12 months through teaching a bedside, special topics and short courses, and start to build process improvement, to then transition after a year to building a team of ER nurse champions or leaders within that hospital. So for example, at ARA, taking 4 to 5 nurses that way as they go on maternity leaves, maybe they get posted to other units. We don't lose that leadership and having only invested in one person. We create a team of leaders, pair them with the nurse mentors to now let them start driving the learning and special topics and short courses, the process improvement for 6 months, to then flip over in the last 6 months to having those ER nurse champions and leaders really running the show, with the mentors backing off and allowing them to lead and own their own processes, to allow this nice arc over a 2-year period of high intervention to local leadership transition. Similarly, with the physicians, what we realized is that when the physician mentor arrives, that immediate disruption, that immediate presence only really works for about 3 months. And then the time physicians have available is so limited that having a physician mentor there every day beyond that, you get limited benefit. And so to use our human resources widely, we can switch to a model where we have this high intensity disruption for 3 months of a mentor. And then the mentor comes back for monthly visits, for week-long bedside teaching, didactic teaching, work on process improvement, where the physicians almost have kind of homework in between on the process improvement. To then move, similar to the nurses, at a year to develop physician leadership, a leadership team for the ER, to again account for staffing changes and departures, so that that institutional knowledge remains at the hospital, where they really take over the leadership alongside the physician mentors. And then again, at the last 6 months, really shift and now partner with their nursing colleagues to be leading their own ERs and pushing that improvement. And through process improvement, we really hope to create better data. So one of the interventions was around documentation. This was in its very early rollout to allow a space so that care gets documented. Data can be generated both for the state for planning and supply chain, but then also for patient care improvement. And so when we think about this outside of Bihar state and sort of step back, what if we wanted to go to Uttar Pradesh, to a neighboring state? Or what if we wanted to translate this to another location, another country that we have worked in who are asking for emergency care services? How would you replicate this package was a really interesting question for us. And so as a team, we thought about what were the critical components. And so the process was really the key stakeholders, having the government engaged, having the deep local knowledge of Care India, having the scale expertise of Care USA, having the technical expertise of our group. So you could take some configuration of this to another state or another country, assigning the roles then across the scopes of work, identifying that local expertise on the technical side, and then developing an implementation plan. And the sort of 4 work areas that are really critical are the infrastructure and equipment, the human resources, the education, and the process improvement. And so to unpack that as a package where you could replicate this, as you plan with the partners and stakeholders, you really need to sort of focus your infrastructure discussions to optimizing the space, augmenting, making it gender empowering, and then focusing on your equipment, your capital purchases, and your supply chain, which again, the different partners have different roles. On the human resources side, working with the stakeholders to optimize that staffing of nurses and physicians, ancillary services like lab and radiology, to then the education piece of what needs to be delivered, how it's delivered, who's delivering it with local and international expertise or just local expertise. And then the process improvement piece. So identifying what standards you'd want to target. And this was not part of our initial work intentionally. And what happened organically is that the nurses and the physicians started targeting basic accreditation standards for a hospital, the cleaning, sterilization, the waste segregation, having a triage protocol. And so targeting these standards in a more intentional way and to allow the hospital to prioritize what they feel is important in implementation, waste versus sterilization, triage versus vital sign protocols, whatever it might be, allow them to work to their priorities to get that process list of targets done and to make it part of patient care on an everyday basis. And so this package, I think, could be taken to other contexts and applied to a group of partners to really lift up emergency services. And this is something that globally we've struggled with. Emergency care is a relatively new focus for WHO, for global entities. There's limited training programs, there's limited content packages, and there's very limited work on how do you do it at scale. And so this project in Bihar provided a really interesting and unique opportunity to contribute to that globally. And so in summary, we are just about to complete this 6-month intervention in these 5 hospitals. This was a 15 million person catchment area that hopefully has access to better emergency care. We've had more than 10,000 improvement hours amongst the physicians and nurses present in the hospitals. There's been some critical process change, sterilization, and the prevention of illness and transmission of diseases. And then most importantly, building of public confidence in the health system. And so this intervention as a health system intervention really emphasized localized leadership and expertise, the frontline health workers who are the front door of the healthcare system every day, and the right to health no matter what the disease or condition. Everybody will be struck by an emergency at some point in their life, whether they're age 1 or age 71, will need an emergency department at some point. And we want to make sure that every set of doors is open and ready to receive whatever patients show up. And so we're really, really pleased and honored to work with the Care India team, Dr. Sanjeev, Dr. Sridhar, our 4 Indian mentors, Dr. Shashank, Dr. Atul, Dr. Ghanshyam, and Dr. Satish, the countless nurse mentors who spent full time at these hospitals as well as our rotating team of international mentors. And so we're really pleased to share this intervention with you, and we'd be happy to take any questions from anybody who's joined in.
Thank you, Michelle. So if anybody has questions, you can either just raise your hand or just chime in with the question by unmuting yourself. I'm looking at actually, I have a quick question is if you could expand a little bit more upon the right to health. So the whole issue about, let's say, gaps in access to emergency care and why that's very important and why that should be included when we talk about right to health, how that's an important component of generally everybody's right to health.
So I think a perfect, really tangible example is none of these 5 hospitals had an EKG machine, which is the only way you can diagnose a heart attack, which means every patient who had a heart attack would go undiagnosed and potentially die either from lack of care or lack of referral. And people having heart attacks are generally middle-aged men, which is not a demographic we often talk about. And the reason that matters is that these are often the primary breadwinners of families. And so this medical tragedy results in a livelihood catastrophe for a family when their primary breadwinner cannot go back to work. Similarly for women presenting for different issues, if they don't have access to safe care with the right privacy in place, may leave the hospital before their treatment's complete. And so we want to make that environment a place where people can receive the care they need to return to their productive lives, whether they're adults or whether they're children who are going to grow up for lifelong productivity.
Thank you. And I see we have a question from Jonathan about, can you talk a little bit more about COVID-19 and how that was involved in this project?
Yeah,
CARE does a lot of focus on that. So
yeah, there's a great question. The project was started really under the impetus of the Delta wave. As we started to roll out, COVID had just sort of started waning in numbers, but the after effects were really quite present. Many of the healthcare workers were quite traumatized, in all honesty. They lost their colleagues, they lost their family members. And so their anxiety around being in the clinical space and providing care was a factor, as well as the need to then learn how to manage more high acuity respiratory or breathing problems. One important investment from Bihar State is that all hospitals were provided with an oxygen plant, and so that all hospitals could have piped oxygen. And this was something that had previously not been available. And so spending the time, as you saw in that word cloud, the word breathing was like huge. And teaching everybody how to use breathing equipment, masks, BiPAP and CPAP, things that had not been easily accessible during that wave, was a real opportunity, as well as maintaining the infection control practices, which was a strong focus of the nurses to try to help prevent themselves from getting sick and feel more safe in that healthcare space. And so COVID played a huge role as this sort of undercutting sort of threat throughout the provision of regular health services.
Okay, thanks. I don't see any other questions, but I actually also had another question. Can you flesh out a little bit more about the gender aspects and the disparity in access from a gender perspective to emergency health services, and why, again, from a gender perspective, that would be super important, because again, that's our bailiwick at CARE? Thanks.
Yeah, so I think there was several gender components. One was the staff. And so it was one of the hospitals, there was oftentimes no nurse at night because female nurses, it was felt to be unsafe for them to be in the hospital at night based on lighting, as well as access to a bathroom in the unit. There was no access. And so it was unsafe for them to leave the unit and walk around the campus. And so some of the nights would go unstaffed by a nurse, which is a very challenging working environment. Patients are not going to get good care. So from a staff perspective, that was huge. From a patient perspective, being able to have nurses who were confident, who are mainly women, receive women and do the more invasive things that would require more privacy, like changing dressings or wounds, treating wounds, doing more physical examination, some of the suturing or stitching up of injuries, which is done by nurses and dressers. Having it done by women who were upskilled and ready to provide that care in a space, renovated by Care India to provide privacy was really critical. And so, women were often not staying if they were recommended to to stay overnight for their condition. Oftentimes they would leave because of those issues, which means they're not getting care. And so I think the gender issues in an emergency department are sort of multifactorial and still need a lot of work. We were able to segregate male and female wards for privacy and make that space sort of really well utilized.
Great. Okay, I see two hands. So Corinne and Jay. Corinne, would you like to go first and then Jay?
Sure, thank you. And my question, you actually started touching on it a bit, because I was also going to ask about kind of what changes were specifically made for the women nurses or health workers or other, hospital staff that were women. I know you talked about the lighting and things like that, but either, what were ways that they needed to be supported specifically, and then also what changes, if any, did you see in the overall quality of care, or just kind of the overall outcome by investing in making those specific changes for women health workers?
Yeah, I mean, it was almost universal that the doctors were male. We didn't encounter any female physicians working. We had encountered a few, like maybe 4 or 5. And so it was a majority male physician workforce and a female nurse workforce, which is sort of the traditional dynamic. And so what we found is the nurses, their skill levels were so low, they felt they were not comfortable speaking up. So they would not necessarily go get a doctor if they felt a patient was sick. They would not necessarily intervene on a patient for fear that the doctor might tell them they did something wrong, or that it was out of their scope. And so part of the intervention was also giving the physicians and the nurses the same skills and the same language to talk about those skills. And so that the nurses could come to the doctor and say, this patient's not breathing well, their oxygen level is low, I think that you should come and assess them, and giving them the confidence to do that. And I think the mentors, especially the Care India nurse mentors, played a really important role in modeling that behavior and making it the norm. And so what we found in the beginning of the intervention is the doctors and nurses never talked to each other. It was like 2 parallel groups of people working in the same space. To the end of the intervention, where the nurses were triaging, receiving the patients, they would grab the doctor for, this patient's sicker than that patient, and so can you come over here? Or I think this patient is changing. It was a really impressive culture shift in just a short 6 months. And I think really modeled very, very well by the Care India mentors, both the physicians and the nurses, because the physicians were then able to model for the hospital physicians, like, oh, when a nurse comes to express their concern, we should react, we should engage and see sort of what's happening with the patient. It wasn't, oh, this nurse is trying to bother me. And so I think that was a really kind of huge change amongst the staff. And we could see that in those trauma and medical observation checklists. In order to do an acute patient on the checklist, it requires physician and nursing involvement. And so some of that low performance in the beginning was only the nurse was there or only the doctor was there. And so as we saw the teams coming together, we could see that performance improve.
That's great. So it sounds like not just skills training for the nurses, but then also ensuring that the physicians are on the same page with them was a big part of it as well. Thank you.
Great, thanks. Jay?
I was particularly interested in how you're planning to measure the impact of this. You've talked a little bit about kind of increased use of checklists, increased confidence, and increased attendance. And I'm wondering kind of what other metrics you might have that would show that either behaviors are changing in hospitals or actual outcomes are changing in hospitals, and any comparison between these 5 pilots and other hospitals, for example, where you haven't been working. And then finally, when might you have something written up that describes this? Because this is just a fabulous initiative and really worth sharing more widely.
Yeah. So I think this is where we set off, and I have to really thank the Care India team. We all sat down together and kind of created a 360-degree evaluation. How do we understand knowledge and attitudes? How do we understand what's happening in the clinical space? How do we understand patient outcomes? And we put all of them into place, which was a huge lift for a 6-month pilot. One of the challenges we found when we started, we did the initial assessments with the Care India team, is that one of the hospitals was not documenting anything, meaning you as a patient could come to that hospital and nothing was ever written down about you and maintained at the hospital. You were given your prescription on your sheet and sent away. And so we went from having one hospital with no record of how many patients were coming through to one hospital that was maintaining records mostly accurately to document who came through, what their diagnoses were, if they were referred. And so one of the main targets that was identified is this lack of data and the ability to aggregate emergency data. And so the picture that I showed you guys of the charting sheets was something that the project team worked on together to create a standardized ER documentation form. And we tried to pilot this through this intervention to see if we could generate better data and be able to know, how many patients with chest pain got an EKG to make sure they weren't having a heart attack, or how many kids with pneumonia got the right antibiotic. This was one of the things that was the hardest to change. The state government endorsed this. They didn't mandate it, but they endorsed it. I will say physicians are very stubborn when it comes to charting. And I will say the same in our own environment. Sean and I work in the ER in the US, and anytime they change the medical record, we're all like, oh, why are you doing this to us? And so getting the doctors to change their documentation was successful in episodic areas, but not consistently. And so as we look at the next phase, Dr. B.K. Mishra, who's the government lead, who is just a force of change. I've never had a government partner so engaged, as this has been clearly successful in a lot of ways. The state government's very happy with it. Moving into an implementation of this scale would come with a mandated documentation change so that we could start to get to that patient level data. Right now, we're sort of stuck with more of that observation of practice and some of the sort of knowledge and attitudes pieces. We do have attendance volumes for a lot of the hospital, many thanks to Dr. Sanjeev and the team.
Thanks. So we have a couple of questions about costs and actually in connection with what Jay asked about impact. I direct everybody to the chat, and Sunil Babu, who's the chief of party for the BIHAR program, actually indicated that one of the impacts, please correct me if I'm wrong, he's indicated that the state government has prioritized emergency care improvement after this 5 hospital initiative in Bihar. And I guess I'm assuming the government's a lot more confident that they can work towards improving complex things like ED. And they state they have sought additional funds from the national government for current fiscal for the first time to improve emergency care in more secondary care hospitals. So that's also looks like one of the long-term impacts about this. But we also, Allison Prather from Care US asked, she asked, can you speak to any specific engagement with the government and thoughts and support to enhance budgets moving forward to help sustain these improvements? I think Lona Stoll indicated a similar question. She was wondering about cost and impact, and which seems critical for scale.
I wonder if either Dr. Sunil or Dr. Sanjeev would want to comment on this. I think that one of the really unique features of this project was that engagement from the government, who actively procured equipment, invested sort of in the human resource shifts. I don't know if either one of them would want to comment more specifically on that government investment.
Yeah. You want me to comment, Dr. Michelle?
Yeah, that would be great.
Yeah, I'm traveling, so I don't know how clear I'm audible. But yeah, just a couple of questions. The impact. I would just want to add to the response that Dr. Michelle has mentioned is that what is the impact the project has bring in is the biggest impact is the change in the behavior. Whether Dr. Sunil sir has already mentioned that government has taken this as a priority, because this is not like any other project. This is more of an academic project which has bring in a hunger for learning new things, and at the same time building confidence in the system that yeah, we can deliver even the emergency services, which was largely seen as a distant dream for the government to think immediately as a priority for them. Hospital has moved beyond the maternal and child health. I will say even the OPD and the IPD for the MCH, and now they are thinking building the robust, which is the face of the hospital, in fact. So that is one thing. And coming to the second point, which Dr. Michelle wants us to comment from our side, is that yes, it's definitely very important that if you have taken one step, government has taken 5 steps. That much I can say, because the efficiency of the work in any other organization like CARE or any private organization is naturally very efficient. When it comes to government, we know how the system works, so they have to take 5 steps to compare our 1 step. So in that sense, I'm saying about this. So government has invested a lot of money into procuring new things, streamlined so many things, deployed HR, even the leadership that has shown at the state level and the district level is marvelous. So that much I can add. And if you have any specific things, then I will be happy to comment.
Thanks, Dr. Sanjeev. I think also in the chat, Lona had a great question about sort of the cost of this intervention and how does this investment in emergency care compare to other health sector interventions? And I think the answer to this is that we don't know. There have been no large-scale emergency medicine efforts that have been able to document patient-level data around mortality, length of stays, able to discharge people healthy back to livelihoods. So there's really limited ability to calculate sort of any of the common metrics like DALYs, et cetera, to understand how much burden of disease are you preventing in emergency care systems, because there has not been any intervention globally to any scale. And so I think that this is also a huge opportunity to look at that and make sure that the value for dollar is there. I think one of the important things about this intervention is that it was designed to be as light as possible. As far as human resources, we did not put in fancy renovations, flashy equipment. This was designed to be function over form and a focus on really what can actually be effective and maintained. And so the lightness of the intervention, I think, is what allows for some of the potential to scale and replicate.
One point I just wanted to supplement in this is a sort of, as you rightly said, there is not so much of a evidence-based cost related, which to prioritize, which not to prioritize, which interventions of health sector to prioritize. But overall feeling level, like the political leadership or the bureaucratic leadership, not just in Bihar, even in other states, like they look at the emergency care unit as something like a mirror of the whole health system. They say like this is where actually it reflects. Whether a health system is able to deliver or not is reflecting here, be it related to pediatric emergencies or obstetric emergencies, or any other general emergencies due to non-communicable diseases and all, which are all increasing among poor people on the ground. So every leadership, governance leadership, everybody wants to invest in it. Having a way to improve their delivery in this kind of a critical area is something that they are looking for. Not just in Bihar, as you were mentioning, in UP, Uttar Pradesh, as well as even in some of the southern Indian states, they're saying functionality of emergency unit has to improve from wherever it is to a next level in every context. It's not like we're going to build a high-end facilities even in secondary care hospitals, but wherever they are, they have to move one step further. Is a kind of realization the people have, and they're ready to want to invest and find ways to do it on ground. That's the kind of responsibility. Thanks.
And then I see another question from Lana in the chat about where we're at as far as optimizing the package of interventions. I think that we have probably another year of work to try to scale out to a larger number of hospitals. And the reason is one, we want to make sure this can be done at large scale. 5 is a pilot, 17 is a real intervention, given that, smaller countries may only have, that or more hospitals doubled. And I also think that, with the process improvement that happened as a positive side effect of the project and the engagement. And so what we want to do in this next year is build that into it. And so that way right now we can write a guidebook for 3 pieces of that pie. And that last piece of the pie is what we want to optimize this year at scale to help be able to then write a guidebook where this could be picked up and put down in Uganda, Bangladesh, Liberia, wherever it might be.
One
Also-
supplement point, one brief one is something which is a differentiator for the kind of approach that has been taken in Bihar is the provision of hands-on, on-the-site kind of capacity, or the mentoring or the training that has been provided, in which an expert or somebody who's an expert is with you when you are treating the patient. When you are managing a case, they are with you, which is not the model which several other initiatives tried out. Even in India, we continue to have some emergency related trainings, which are more like a classroom using the mannequins kind of a thing alone. There is no one when you actually are managing a patient. That kind of a on the site hand-holding support for few months at least probably gives a lot of confidence and ability to handle things in future. So that kind of a component is very essential, and that needs to be costed and built in wherever.
Thank you. And I see we're coming up to the top of the hour, but there was one question, maybe this, I'm not sure if you know the answer, Michelle, but Jonathan was asking, are there specific prospects? Are there prospects for future funding for future opportunities that you've been talking about?
Yeah, so we are, as a team, actively looking. And so the state government obviously is quite invested and is looking to allocate resources towards emergency care. The Care India team has been looking in the private sector and around India. And then we as the Harvard team have been looking sort of outside of India for opportunities for funding to take this to scale as sort of a first ever large scale emergency medicine intervention.
Thanks. So we are at the top of the hour. And again, thanks to the folks from Harvard for all the work in putting together this presentation.